everyone, welcome to researchundy.com. We got our morning report presentation today. We got a great case, right? Is that true?
Yes.
All right. So, are we ready to start? Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. Just a brief introduction, and I've been teaching medical students and residents for a very long time. I'm also an assistant professor of two large medical schools. So, let's start our case today.
A 79-year-old male presented to the emergency department with worsening jaundice for the past 3 days.
Hold on 1 second. 79-year-old male
Presented with
complained of jaundice,
Yes.
right?
He also complains of pruritus for the past.
Okay, let's observe right here. So we are like those, anytime, what did I teach you? Like the first thing I would do is like, is there an emergency? When I talk about emergency, like a surgical emergency, or you need to act on it right away. In jaundice, I don't think, can you guys think of anything? I don't see anything kind of emergency we need to act on. We can take our own little bit of time and see like what's going on. Nothing urgently need to be done. Everybody agree with that? Now let's talk about our differential diagnosis on jaundice. First of all, that we need to know what is jaundice. When people say like bilirubin, is there a number? Somebody give me a number. Everything we need to express in numbers. If we cannot express in numbers, you don't know the thing, right? So what is the number if jaundice and the bilirubin level?
2.
What is it?
2.5.
No, 3. Okay, remember 3. Everybody remember that 3 is the magic number. If it is greater than 3, you can say it has to be greater than 3 to the body to express the jaundice. Okay, where do we usually look for? In the sclera.
Yes.
Then you can look at the tongue, the fingers and all that. But you usually cannot look for sclera. Okay, so when you talk about, let's talk about differential diagnosis. The first one, we just talk about the hepatocellular causes, okay? Everybody agree with that? Hepatocellular. So what are the hepatocellular causes? Somebody tell me. It could be like chronic liver disease, right? Chronic liver disease.
Yes.
We'll say chronic liver disease. Okay, something else.
Cirrhosis.
Cirrhosis. Yeah, that kind of go both of them. Cirrhosis, chronic liver disease lead to cirrhosis. Okay, what else?
Drug-induced liver injury.
Very good. Drug-induced
liver injury.
Liver injury. Okay.
Autoimmune liver disease.
Autoimmune liver disease, yep. What are some autoimmune liver disease?
Autoimmune hepatitis. Primary
Louder.
Primary sclerosing cholangitis.
Yep, primary sclerosing cholangitis, right? Autoimmune hepatitis and all that too, right? Viral hepatitis, right?
Right.
No one told me anything about it, right? You got hepatitis A, B, Z, or you have Epstein-Barr virus, viral hepatitis.
Yeah.
Okay.
Inherited disorders.
Yep, we can say inherited disorders. What are the inherited disorders?
Hemochromatosis.
Wilson's.
Wilson's. Yeah.
Yeah, 2 things come to my mind is like hemochromatosis, right? And the Wilson disease with the copper level and those kind of things, very, very important. Examination questions. So everybody understood the hepatocellular causes, right? So I'm just going to say again, chronic liver disease, cirrhosis, viral hepatitis, right? And drug-induced liver injury, and you got autoimmune disease and inherited disorders, right? Now let's look up at the biliary causes. What are the biliary causes of jaundice?
Any obstruction.
Okay, any kind of obstruction. What do they usually get obstructed? Gallstone, right? Gallstone obstruction. Okay, what else? What else do we have? Any kind of malignancy, can it obstruct? Okay, malignancy obstruction. Right? What else?
Again, autoimmune cause.
Yeah, autoimmune. Yep. Let's say autoimmune, we can kind of put it in there. Okay. What are the other causes? Let's say hemolysis. Can it cause?
Ischemic cholangiopathy.
Okay, we can put that ischemic cholangiopathy. Okay, now let's talk about hemolysis. Can hemolysis cause jaundice?
Yes.
Yes.
Yep. What are the hemolysis causes? What can we say? How do we define? How do you we can say what? Intracorpuscular and extracorpuscular. Okay? You got it? So let's say what are the intracorpuscular? What are the causes of intracorpuscular? Okay.
There could be membrane.
Any kind of RBC interior defect, right? And that could be like a membrane defect, right? RBC interior defect. And then we have what? Membrane defect.
Yes.
Okay. So what will be the RBC interior defect? What kind of things we have? So like RBC interior defect. Which one? Enzyme defect and hemoglobinopathy?
Yeah.
Okay. So we got enzyme problem and hemoglobinopathy,
Yes.
right? Which is what? Sickle cell?
Yes. Thalassemia.
Let's say sickle cell more like a more really like,
Yes.
hemolysis kind of happen, right? More common. Thalassemia, rare. Membrane defects. Huh?
G6PD.
G6PD, very common if you need to know when you talk about G6PD.
Pyruvate kinase.
Pyruvate kinase. Okay, and then what do we have?
The membrane.
Extracorpuscular. Or the membrane, like what are the membrane defects? Hereditary spherocytosis. Everybody know that, right? Hereditary spherocytosis, right? And then PNH,
Yes.
right? Paroxysmal nocturnal hemoglobinuria, right? That can cause pulmonary embolism and those kind of things. So we'll come back to some of that and all that. And then what are the extracorpuscular causes?
Autoimmune, hemolytic anemias.
Okay. Let's say like a spleen, they can dispose the hypersplenism, like one of the main common, right? Let's say hypersplenism. What else? You said what? Autoimmune hemolytic anemia, AIHA. Okay. What else?
Infections.
Any kind of infection, sepsis. Anything else?
Microangiopathic.
Microangiopathic hemolytic anemia.
Or it can be macro.
Microangiopathic hemolytic anemia, right?
Micro and macro both, yes.
Both of them can cause. Okay, so we got now the most important, what condition you can mimic of jaundice. It's not actually bilirubin is not elevated. When you have jaundice and the bilirubin is normal, okay? So what conditions are mimic the situation? Mimics everything we need to know, right? You check and they say it's not the bilirubin is kind of normal, you still have jaundice. Give me some condition, what food product? Carotene, right? What is it called? Beta carotenemia?
Yeah.
Right?
Yes.
Okay, and then this drug called a malarial drug, quinacrin. Okay? That can have any other thing can cause, you can have Addison disease, you can have anorexia nervosa, anorexia nervosa. Okay? So you have to think about the other causes. Let's say somebody have some occupational exposure also, and those kind of things we need to know. Okay? Everybody understood this? This is a major kind of differential diagnosis we have to think about it when you talk about bilirubin. Again, jaundice greater than bilirubin level greater than 3. That's where manifestation kind of comes into. Okay, now tell me about this case. So, explain the case a little bit more. So, only thing we know, you got a 79-year-old male with jaundice. So, what are the other symptoms he was having?
Yes. So, patient also complains of pruritus for the past week.
Pruritus, okay.
The patient also mentioned that he lost 20 pounds in the last 2 months.
20
and has
lb weight loss. Okay.
Yes.
Am I happy with that? When somebody said 20 lb weight loss, come on. What should I ask? What's the question I should ask? Come on, guys.
History of it.
No. What should I ask? Nobody. Come on. Somebody.
Is it
intentional or non-intentional? Okay. So what is it intentional or non-intentional?
Non-intentional
Is
because
it non-intentional? Right?
Yes.
Is it important? So everybody in the world is trying to lose weight now.
yes.
Right? So if you lose 20 pounds, people dropping 50, 100 pounds really fast now. Right? So, non-intentional I'm worried about. What else?
The patient has also said that he feels tired and there's lack of energy in the past 4 to 6 weeks.
Okay, tired, okay.
And also has had lack of appetite and altered taste for about the past month.
Decreased appetite. Okay. What else?
And he says that he has seen his urine like tea or dark amber in color,
Urine dark. Okay.
and stools have been lighter brown in color.
Stool pale.
Yes.
Okay, very good. It's always like people always forget to ask the urine color and the stool color. Why is that? Why do we need to ask for that? The urine color and the stool color. Because obstructive jaundice, right? That can cause us like, I mean, we'll come back to, come back to that. So this is the only thing we know. We know this is a patient. To summarize, what? We got a 79-year-old male. Come with the jaundice, right? You got pruritus associated with it. And is it important to know, is there any pain? Was there any pain associated with it?
He didn't mention any pain.
Why is that important to us? What is the like a painless jaundice? What will come to us right there?
I think it's malignancy.
Malignancy. Okay, so always got to think of somebody with the painless jaundice. You always have to think about malignancy. Okay, painful jaundice is pretty much you can kind of say and all that too. So now when we talk about all this, let's talk about the past medical history, right?
Yes.
What past medical history is important to us? Right? We talk about a lot of disease up here. Malignancy is important to us, right?
Yes.
What else is important? Liver disease, like history of liver cirrhosis is important to us, right?
Yes.
What else is important to us? Any kind of autoimmune liver disease and all of those kind of things important to us, right? Does this patient have any of that? What is his past
Patient
medical
just
history?
has hypertension, diabetes, and coronary artery disease.
You say hypertension and diabetes?
Yes.
Okay. You got hypertension, diabetes. Okay.
Yes. And coronary artery disease.
And coronary artery disease. We got hypertension, we got CAD, right? What is the next thing?
So
We need no family history. Somebody tell me
Yes.
why should we know about family history?
any hereditary.
Inherited disorders, right? All of this kind of liver diseases, we need to kind of worry about it, right?
Yes.
Everybody knows that. Okay, what else we need to know? Family history, medication. Why is medications important to us? Meds. So somebody like which medication can we be like drug-induced liver injury? We said that already, right?
Yeah.
DILI, drug-induced liver injury. So which drug is like very common people take and get into trouble with the liver? Which one is that?
Rifampin.
Huh?
Rifampin.
No, like how many people in the world? Tylenol, right? The Tylenol, like everybody take it for pain now. This says Tylenol. So Tylenol toxicity we need to know. This patient have any history of Tylenol?
No.
Okay, what other drugs can you like? You said rifampin?
Rifampin.
Okay, what else?
Probenecid.
Probenecid, okay.
Ribavirin.
Okay.
And protease inhibitors.
Protease inhibitors. And those kind of common drugs like rifampin. You said INH also. Did you say that?
INH.
That can also
INH
cause us,
also.
right? So any of this drug, one drug the patient is on can cause liver injury.
Patient is just taking metformin
Okay.
and
So metformin, right?
metformin, yes.
Metformin. So anything when a patient comes is like that, what I do is like I get my drug information. I try to look for that drug interaction and drug complications. So many drugs kind of go through liver and get metabolized, right? So we don't know. Like it's very good to check it out. Okay. So what else do we need to know? Do we need to know the social history?
Yes.
Is he a smoker?
Yes.
Why is it important? Malignancy, right? What about alcohol? Do we need to know?
Yes.
Why is that? Liver disease and liver cirrhosis, liver cancer, and all of this kind of in common in these people, right? Does he have any of that?
Yes. He
Okay.
smokes 2 packs per day for the
He's
past
a
25
smoker,
years.
yep.
And he drinks 4 beers per week for the past 25 years.
Okay, it's not like men has to drink what? Like rather than 2 beers. I mean, to call it like alcoholic, 2 beers per day, right? And female has to be like 1 beers per day. But it doesn't look like he's not a chronic alcoholic. You guys agree with that? Okay, social, like sexual history. Why do we need to know sexual history?
Hepatitis.
Hepatitis, viral hepatitis, right?
Yeah.
What else? Anything else? HIV cholangitis is like very, very deadly. Okay, remember, if somebody have HIV and you have low CD4 count, once they develop cholangitis, the death is like 95 to 99% probability of they going to die. Okay, and then psychiatric history. Again, a lot of medication, they can cause like, liver injury in that. So I would watch it. Other than that, I don't see any kind of psych history problem. Okay, vital signs, somebody tell me the vital signs.
Yes. Patient's blood pressure is 140/75. Temperature is 97.9. Pulse is 87. Respiratory rate is 18. Saturation is 99%.
99%. Okay. So vital sign doesn't tell us that much anything about it, right? Everything seems to be like pretty much normal, right? Okay. Now we just go into physical examination. What's the first thing when the patient come in? What are the things we have to look at it? I mean, there's a patient right there. I'm walking in. What is the first thing we have to do? Somebody tell me.
The appearance.
Appearance. Why is it appearance important to us? How does he look, right? Does he look jaundice and all that? Jaundice is better seen when? Like, I mean, within the artificial light or the natural light?
Natural light.
Natural light. Turn the lights off, put him in the window on your side, kind of look at the patient very carefully. Okay, he looked at the patient and he said jaundice. What else you need to by looking at the patient?
His eyes for...
I mean, you already said that, but what does this say? 20-pound weight loss. Why should I worry? I like to see this cachectic. That's what I'm looking for, right? I see if any cachexia kind of going on because you have loss of appetite, 20-pound weight loss. You can ask, what are the questions? How can you ask about weight loss and all that to a patient? Always ask, like, they might not know. Have you noticed any of your shirt kind of become looser? Or somebody have to, those are the best way they can kind of remember. Otherwise, people might not remember. Okay, the clothes they wear. So physical examination, what else is important? Somebody tell me. What is the next thing in the physical examination altogether? Before we go into specific system-wise, what am I looking for? General examination, skin examination. Why is it important to me? Come on. Liver disease, right? Yes. Liver disease can have so many signs, right? Yeah. So let's start. Somebody tell me liver disease like what? Sclerotic tract, icterus, right? And then what is in the hand? What can I see?
Pale, like
what is it? Palmar erythema. That's what I'm looking for, right? Palmar erythema. And then if you want to look at the signs, you can see asterixis, right? And then what?
Spider
angioma. What else? Gynecomastia, right? Yeah. What else?
Caput medusa.
Caput medusa. What happened to my umbilicus?
Aborted.
Huh? Yeah, protruding umbilicus, right? Ascites, and then testicular atrophy. All this kind of things, and also some nail change is also going to be there. So I always look for that. Okay, and then what are the things? What are the what do we have to do? What examination we have to do? General abdominal examination. I start with the umbilicus, the position, right? And then I check for shifting dullness. I look for masses. All of that is important. You have to do a very systematic kind of thing. So any of this positive in this patient? Somebody?
No.
Only what we don't know.
No.
Okay. Everything was unremarkable other than jaundice. But he has jaundice.
He has jaundice, yes. Okay. And his skin was warm and dry. And
all right, jaundice positive. Now we just kind of did our examination. So based on all this, what's our differential? Everything. 95% of the time, our diagnosis come from history and physical examination, right? So somebody tell me, based on this, what we know so far, what is the #1 diagnosis you can put in this patient?
Malignancy.
I would go malignancy. Why? It's painless jaundice, and he got 20-pound weight loss. He's 79-year-old, right? History of smoking. He got alcohol. So I'm still kind of thinking malignancy at the differential diagnosis. Then I try to do what labs I need to order. So somebody tell me what I know. Don't tell me any of the labs. Someone tell me which labs they have to order. What labs should we start with first?
CBC.
CBC. Why is it CBC is important?
To rule out infections.
Rule out infection, maybe cholangitis, those kind of things. Okay, there is an infection, right? Cholecystitis, those kind of things we need to kind of think about it.
Even anemia or something.
Anemia we need to know, right? Platelet count, what happened to the platelet in liver disease? Why is that?
Because
thrombopoietin is produced where? Liver. Okay, so there's always kind of thing, those kind of things you have to look for, right? We have to know that. And then we need to know what are the things we need to know right here. Sodium is important to us?
Yeah.
Okay, anytime there's cirrhosis, right? There is fluid retention, hyponatremia, right? Beer potomania, all of this kind of things important, right? Potassium is important to us?
Yes, hepatorenal syndrome and all this maybe leads to renal failure.
Okay, we'll come back to that. And then chloride and the bicarbonate. You know, any kind of abdominal infection, lactic acidosis. Acidosis is kind of important, right? Biliary creatinine, you already said like what? Hepatorenal syndrome. If this patient had a renal failure and hepatorenal syndrome, and then that's the mortality is like extremely high. Okay, well, how do you treat hepatorenal syndrome? Is there any treatment first of all?
No.
I mean, the only thing, yeah, you can do transplant, but albumin have a little bit of role. Study is still not very clear, but the mortality rate is extremely high, my friends. Okay. Anything else? Any other labs important to us in this patient?
LFTs.
LFT, okay. What else? What else is important to us? What are some functions of synthetic function of the liver?
Bilirubin.
PT, INR, right? INR and what else? Albumin.
Albumin.
Okay, we'll start with the PT, INR, right? Albumin. This is synthetic function of the liver. Okay, what else we need to know? No? Any other labs important to us? Can't think of anything else. What about urine analysis? Do we need the UA? Right? What do we, I mean, you know, we talk about the urine color, like an urobilinogen, those kind of things. Urine analysis is kind of important, right? Anything else? Which one?
ECG. ECG.
ECG. Somebody with the painless jaundice and 20-pound weight loss, you want to do an ECG? Who's going to pay for it? You going to pay? You got how much money in the bank? Value-based care, okay? Just be careful when you, sometimes when we make, I mean, I'm just noticed that, like, I mean, let's say I'm the attending, you coming to me presenting this, right? And then what is the impression you're creating? You have to be very careful. You know, people say you can make all the mistakes and all that in the word, but one comment sometimes you make, you have to be very, very careful, right? You went to medical school and all those kind of things. Like if somebody, 79-year-old, painless jaundice, 20-pound weight loss, we already talked about what? We already talked this could be like a malignancy right here. So unnecessary doing taxi, you do an ECG and then you got an ST depression. What are you going to do? Right? Those kind of things is important. All right, so tell me the WBC. What is the WBC?
Yes, it's 4.5.
Okay.
Hemoglobin was 11.8.
Okay.
Platelets 150.
Okay. Sodium, potassium?
Potassium, sodium was 138. Potassium 3.9. Chloride 102. Bicarb 28. BUN was 18 and creatinine was 0.8.
0.8, okay. And LFT, tell me the LFTs.
Total bilirubin was 12.
TB 12, okay.
AST 127. ALT 228. And alkaline phosphatase 757.
757, right?
Yes.
So, we need to know total bilirubin. What are the things? We need to know either direct or indirect bilirubin. Do we know that? Right?
Yes.
Everybody agree
Yes.
with this, right? We need to know fractionated, my friends.
Yes.
Fractionated, okay? And then we need alkaline phosphatase, right? Remember we said like we need to know where it's coming from.
GGT.
GGT need to be checked, right? So check GGT. Did they check that?
No.
Okay. Then we need to know it's fractionated where it's coming from. Right?
Yes.
And is there a role for check for like reticulocyte count in this patient? Is there any kind of hemolysis? But there's not much anemia right here, right? Maybe a little bit of anemia, reticulocyte count maybe. Check GGT, check like fractionated. What else? Lipase. Do we need to check an abdominal lipase in this patient?
Yes.
Didn't have any. I mean, I think it's not unreasonable. But just check a lipase. Do we have a lipase on this patient? Do we have?
No, we did not.
You sure? Double check.
One second.
I mean, if it is not there, that's okay. Just double check and did anybody did a lipase on this patient?
Lipase was 726.
Okay, so make sure, like, I mean, you know, when you present, that's another problem. You have to know in and out. Okay, everywhere, like all the things and all that. You don't want to make a mistake. We do the first impression, always the best impression, right? Your thought process, you can like that impression you create on people, and when you have all the labs and all that. So it's very important to look at the labs, okay? So based on all this, what do we know so far? What is our diagnosis, right? What is our diagnosis? Right? We can say like, no, we don't come into like, what are the like, what is the next step? Do we need to do any investigations?
Yes, so we did ultrasound.
Okay, what did the ultrasound show?
The ultrasound of the abdomen had the bile duct was dilated, measuring 14 mm.
Common 14 mm. Now I'm going to ask my question again. What's the normal size of the common bile duct? I have told you so many times, if I hear the wrong number, you're gone. I'm warning you. You have to like one number you need to know. What is the normal size of the common bile duct?
8 mm.
Oh, you're killing me. What is the normal size? You tell me.
4.
What is the normal size?
6.
I'm going to quit. 6 millimeter.
Yes.
Okay. I think I had to be like Dr. House to me to treat you all. Too nice to you all. So you have no 6 millimeter. Common bile duct is extremely elevated, 14 millimeter. Somebody tell me like what condition you can have dilated common bile duct.
Elderly.
Elderly, you can have senile post-dilatation. Usually around 8 to 9, 90-year-old grandmothers come in, and then we know that is common bile duct elevated. Could be senile, but still have to rule out the other causes. Could be stones, right?
Yes.
Could be malignancy, right?
Yes.
What else?
Post-operative as well.
Post-cholecystectomy. The first thing always kind of like, to find out this patient have a gallbladder or not. If this gallbladder is taken out, the dilated common bile duct even go to like 12. If it is 14, it's still high for that. Okay? I know there's an obstruction, so what is my diagnosis?
Doctor, we also did the CT angio of the abdomen.
Okay, let's see, obstructive. So did a CT?
Yes. There was pancreatic head dilatation.
Okay, what is the CT scan finding?
There was pancreatic head dilatation.
Oh, pancreatic head dilatation.
Also, there was soft tissue prominence in the pancreatic head, and peripancreatic lymph nodes were seen, measuring 1.1 centimeter.
Okay, pancreatic duct dilatation. What is and then some lymph node around the pancreas,
Yes.
right? Lymph
Yes.
node positive. Not good, right? So there is a question of malignancy kind of going on. We don't know, but we just have to be very careful right now. So when you have this pancreatic cancer, what's the marker we have to do in this patient? What do I order? Somebody tell me what's the marker?
Yeah, 99.
CA 19.9. So it's a good idea to check CA 19.9. Okay, I don't know. They checked it. But I would do, my next step is this thing. Okay, so what is my diagnosis? I will write obstructive jaundice, right? Malignancy, can I write that? Most likely, right?
Yes.
Right? Abnormal CT with the pancreatic. Abnormal CT, right? Questionable pancreatic malignancy. Can we say that?
Yes.
Okay, what is supporting the obstructive jaundice? We got a bilirubin. I don't think you guys did fractionated, right?
Yeah.
We need to do the fractionated. But we know the CT scan, we know there's pruritus, there is malignancy and all that too. So what's the next step? We need a GI consult, right?
Yes.
And then we'll check the marker, CA 19.9, right?
Right.
And then we consult surgery and oncology, agree?
Yes.
Okay, now we have like a lipase elevator, right? Why do you think the lipase is elevated? Maybe because pancreatic duct is obstructed, right? So there's some pancreatitis we can say, like, right? You can say pancreatitis. Anything abnormal here? So everybody got that?
Yes.
Okay, so remember this is a great case, obstructive jaundice, somebody with a painless jaundice and pruritus. You have to think malignancy as the number one. Thank you so much, everyone watching today. If you have any comments and any other points you want to add, let's make it a discussion. Put the comments under the discussion section. And thank you so much. Greatly appreciate it. If you could subscribe to our channel, it definitely help us to make more videos like this. Okay, take a lot of people's effort to make videos. Please help us. Thank you so much.